Thank you, Sue. I'm talking to you today about the basics of Parkinson disease. Thank you, Sue. And what the latest is and where the field is going in the next 5 to 10 years as I begin this journey here at Baystate. My goal is to bring patients in Western Mass the best Parkinson disease care that is currently available. And that includes diagnostic techniques and the most advanced therapies. So without further ado, this is the first part in hopefully a 3-part series. So join me back over the next few months to learn more. I have no disclosures. I have no financial obligations to the tests or medications that I may talk about today. And just to provide a roadmap of where I'm going today, I'm trying to keep things as simple and straightforward as possible, as I know people's education and knowledge about the disease may range from a very basic, it's a disease that involves tremor, to something more nuanced. We may have caregivers or family members present. I'm happy that you're here as well. So what I would like to present to you all today is a new way of thinking about Parkinson's disease and how we're going to be going about diagnosing it earlier and with greater confidence. Then I'll go into how I classify a patient with tremor when they come to see me here in the clinic. Just to give people reference, my clinic is here in Springfield at the 3300 building. That's separate from the main hospital building. And then I'll go into a little bit about what we know about Parkinson's disease and what's actually going on in the brain that produces symptoms that we recognize. Finally, what techniques do I use to secure a diagnosis, and what my practice philosophy is when I diagnose a patient with Parkinson's disease. I'll then spend the remaining time going over medication and advanced treatments, but I do want to leave room for questions at the end. So if you do have a question, just submit it in the box and I will try my best to get to it at the end of the talk. Thank you. So what do I mean by a new paradigm of how we conceptualize what Parkinson's disease is? So classically, the description by Parkinson himself was this old man stooped over with a tremor and shuffling as he walked down the street, possibly with a cane in hand. However, what I would like you to do is to refocus your attention instead of on a man with a cane, instead to a long freight train. And the reason why I picked a train as a new metaphor for Parkinson's disease is that a freight train is very long, and sometimes we can hear it coming from miles away because of the sound that it makes. And as we know, the longer trains are and the faster they're going, the harder it is to stop them. So the metaphor that I have is trying to get at what do we define as preclinical, or what others may call prodromal Parkinson's disease. So if you think of each of these symptoms that I have in front of you as a train car being added onto the freight train coming down the track, if you start developing a loss of a sense of smell, constipation, or what we call dream enactment behavior, that's also known as REM, sleep behavior disorder, where patients act out their dreams at night. Orthostatic hypotension, and an explanation of what that is simply going from a seated to a standing position produces lightheadedness, dizziness, or even syncope or passing out. And then finally, a mood disorder, either depression or anxiety or both. Now, you may ask yourself, hey, I have one of these symptoms. Do I have Parkinson's disease? The answer is probably no, but if you find yourself starting to develop a constellation of 2 or more of these symptoms, think of it as piling symptoms onto your train going down the track, headed towards Parkinson's disease. As you add more and more of these preclinical symptoms, it's going to be harder to stop the train from coming down the track. And therefore, that begs the question, how can we recognize Parkinson's disease earlier? How can we stop the train from going down the track and stop its momentum from developing into full-blown Parkinson's disease, the shaking palsy? So a lot of people and in the media are focused on tremor and Parkinson's disease, and they have every right to be. It's sometimes the most outwardly visible sign that something is wrong. Now, what is tremor? A strict definition of tremor is someone who has a regular oscillatory movement. Think of a pendulum swinging back and forth at a various frequency and around a certain axis point. In Parkinson's disease, what I look for is this kind of tremor, but also other features that come along with the tremor. Now, how do I classify tremor when a patient comes to see me? Well, how far back and forth is the movement? That's called amplitude. That can be a millimeter, a centimeter, or even 5 to 10 centimeters for patients who have large amplitude tremor. How fast are they moving when they're moving? That's called the frequency. People can move very fast, swinging back and forth, or they can move very slow through the movement. What body part is affected? Is it a hand, or is it a foot, or both? Do they have involvement of their head or chin? Is the tremor happening on both sides of their body or one side of the body? And finally, I leave this last section as the most important. When do you notice the tremor the most? Is it at rest when your hands are sitting comfortably in your lap while you're watching television? Or is it when you're trying to use your hands, for example, feeding yourself with a fork or spoon or holding a cup of water? Finally, when you're trying to use your hand in a certain posture, for example, holding your phone or holding the newspaper in front of you. These are all features I use to classify tremor and help me narrow down the list of possibilities of what could be causing it, one of them being Parkinson's disease. I also leave the bottom with associated symptoms because I do not make a diagnosis of Parkinson's disease based on tremor alone. And I'll get into the strict definition of what Parkinsonism is later in the talk. But other than just having a tremor, there are other things that I take into consideration. So how do I define Parkinson's disease, or how does Parkinson's disease come to be diagnosed clinically? And then I'll also spend some time going over what Parkinson's disease looks like under the microscope, and then how we'll bring those two together into a nice package to come to a diagnosis. And I'm asking these questions rhetorically with hope in mind. Can we improve the accuracy of diagnosis of Parkinson's disease while someone is alive? And can we diagnose Parkinson's disease earlier, before the onset of the movement disorder, vis-a-vis a patient's tremor? I'll give away the spoiler. The answer is yes for both questions. And this is what is exciting in the field at the moment. So you may have found coming across your reading or at a doctor's appointment or on your visit summary that their doctor has listed that you have Parkinsonism. What does that mean? Sometimes patients panic and think that Parkinsonism equates to Parkinson disease. However, I'm here today to kind of bust that myth and further explain to you what the difference is between Parkinsonism and Parkinson disease. So in the strictest definition, Parkinsonism is at first and foremost slowness, what we call bradykinesia, and one of the following, either stiffness in the muscles, or what we would refer to as rigidity, or a tremor at rest. Remember, going back to how we classify tremor, it can be with posture, action, and at rest. Specifically, with Parkinsonism, we are looking for tremor at rest. I highlight on the right hand of the screen a breakdown of patients that came through a very busy movement disorders clinic over the course of a year. And as you can see, there were a little under 11,000 patients with Parkinsonism. However, only about 7,000 of them met criteria for Parkinson disease. Now, you may be asking yourself, what do the other 4,000 patients have if they don't have Parkinson disease? Well, I'll go into that next. So Parkinsonism is an umbrella term. Under that umbrella, you can have different causes of these symptoms, the slowness, the rigidity, or the tremor. And as you see coming into view, various causes of Parkinsonism. You could have a drug that you're on that's causing these symptoms. You may have had a stroke. You may have had trauma to the brain that's producing your tremor. In the middle, I have idiopathic Parkinson disease, the neurodegenerative disease that my patients have that I follow through my clinic. Parkinson disease is the neurodegenerative disease that I am focusing this talk on today. However, you may have symptoms of tremor or slowness that may be caused by an alternative brain lesion or a medication side effect. And that's why I list them under the umbrella, as you can see here. It gets even more complicated as we go down the path of Parkinsonism, as there are some more rare related Parkinsonian disorders that also are caused by the same misfolded protein in Parkinson disease. And I list them here mostly to be complete, but most of the time patients don't have to worry about this unless they do not respond to the medications used for Parkinson disease. And just to list them, they would be Lewy body dementia, multiple systems atrophy, progressive supranuclear palsy, and cortical basal syndrome. But for the purposes of the remaining talk today, it will be on Parkinson disease. So let's get down to business here with Parkinson disease and what's going on with our brain cells that causes the disease. We've identified a misfolded protein that's produced by our dopamine brain cells in the deep part of our brain. When these proteins get together, they clump up the neuron or brain cell and interfere with its ability to transmit our electrical chemical brain signals that allow us to move in a voluntary way. And I say that because I characterize voluntary versus involuntary movement because in Parkinson's disease, as opposed to other movement disorders, it is a disorder of lack of movement, as opposed to a disorder of too much movement. And that's dependent on the brain circuit that's affected. Now, where in the brain is this happening? So if you think about the brain, I'm holding up a picture of one. And we cut it in cross-section right across the forehead and look at a section coming down from above. We see the brain stem and what's the part of the brain stem called the midbrain. And in the midbrain, there's a collection of dopamine cells or brain cells that produce the chemical dopamine. And on the right part of the slide, they're stained this dark color. And this is the collection of cells that tends to degenerate in Parkinson's disease. A healthy midbrain is nice and dark with pigment here in the brain. However, in Parkinson's disease, we see that there's not as much pigment, meaning these cells have degenerated. Now, we can't open up the brains and make pretty little slices of brains to look at under the microscope to be sure of a diagnosis of Parkinson's disease during life. So that opens up the question of, well, how are we going to be sure of our diagnosis? Well, we use two features. One is our clinical exam and history that I take during the visit, where I pay attention to those prodromal or preclinical signs of Parkinsonism that may go along with their tremor disorder. And then I also use, in some cases, ancillary testing or tests that may be helpful in narrowing down the list of possibilities of what's going on with the patient. So over the last 10 to 20 years, the most common ancillary or helper test that neurologists have used is called a DAT scan. And how I explain a DAT scan to patients, if it's needed, is that we are looking for a loss of those dopamine cells in the deep part of the brain. And the way that we do that is by injecting a small tracer molecule that gets absorbed by the remaining cells. And then we take pictures of the brain once it's absorbed to look for a bright comet-shaped signal on both sides of the brain. So as you can see here, on the left side of the brain, we have two bright comet-shaped signatures of a healthy patient who does not have Parkinson's disease. However, on the right side, the comet has lost its tail, which shows us that there's something wrong going on in the brain and a loss of dopamine cells there. The dopamine cells that produce the chemical dopamine are necessary for us to move the way we want to move. And if there is a loss of those cells, it produces the signs and symptoms of Parkinsonism. And I say Parkinsonism instead of Parkinson's disease because the DAT scan is not 100% specific for Parkinson's disease. You'll see an abnormal DAT scan in patients who may have another disorder other than Parkinson's disease. So it's not where we hang our hats as neurologists. It's still important at the end of the day to take a history and physical exam and have the patient in front of us before determining a diagnosis. A DAT scan is not an MRI. It is a nuclear medicine scan the technique of the imaging is slightly different, and it does not use magnetism or X-rays to get its results. Now, other than the DAT scan, what other tests do we have to help us diagnose Parkinson's disease? Because even as movement disorder specialists, such as myself, we're not 100% accurate with diagnosis either. And it's a very humbling experience to see patients and have them in front of you and not have all the pieces necessary to make a firm diagnosis. And most of the time, I'm honest with patients if I'm considering an alternative diagnosis or if I do not have all the information that I need. And so what is helpful that has been discovered in the last few years that I'm integrating into my practice here at Baystate? Well, it's going to be the pathology, the actual misfolded protein itself. So going through this timeline, we've seen that we've detected the misfolded protein called alpha-synuclein in the cerebrospinal fluid of patients as far back as 2016. And we've also identified it in the olfactory or cells that are responsible for our sense of smell. And most recently, we've identified the misfolded protein in patients' skin. And a commercial test has recently become available that I've integrated into my practice that detects the abnormal protein in a simple skin biopsy. In the near future, I foresee the field even detecting this misfolded protein in a patient's saliva. We are not there yet, but I think that's what's on the horizon. In the corner is a dopamine cell with dark body inside of it with misfolded protein. That is the alpha-synuclein that is clumped up and clogging up the dopamine cell and causing it to degenerate. It's been very promoted in the media lately, this test for alpha-synuclein in cerebrospinal fluid and in skin. This was just published at the recent meeting of the American Academy of Neurology, just this past April. The sensitivity and specificity of the test reaches over 90% in patients where there is a high clinical suspicion for Parkinson's disease, as opposed to the DAT scan, which is not as specific for Parkinson's disease. Now, what do I do for a patient who comes to see me and we are obtaining this skin biopsy test? It is a 3 millimeter skin biopsy taken from behind the neck, on the thigh, and above the ankle. It is a non-sterile procedure that's done in under 30 minutes without anesthesia or much bleeding or incision. Typically, patients go home with 3 Band-Aids at the end of the visit without complication. The samples are sent off to a lab that processes the samples and uses advanced microscopy techniques to determine if the sample is positive or negative. And usually I go over these results with the patient within 4 weeks of the skin biopsy. Now, is a skin biopsy or a DAT scan necessary for a diagnosis of Parkinson's disease? No, the answer is no. If a patient fulfills the clinical criteria for Parkinson's disease and other causes of their Parkinsonism are ruled out, a patient can be treated for a diagnosis of Parkinson's disease without additional testing. That's the second myth I hope to dismiss today, is that there is no test at the end of the day that's going to confirm 100% you have Parkinson's disease. But with a history and exam that's suggestive of the disease, and our newest tests that we have available, including the skin biopsy or cerebral spinal fluid, we're almost 97% of the way there. Now, I do not just diagnose patients with Parkinson's disease. I also treat them and follow them for the remainder of their lives. And the first tenet of my philosophy is that Parkinson's disease is not a life-limiting disease. It is not a terminal illness. However, patients do develop a varying degree of disability along the way that mainly comes in the form of their ability to walk, swallow effectively, or think clearly. And my goal for every patient is to limit those complications if I can. Now, a lot of patients also ask me, is there a cure for Parkinson's disease? The answer is no at the moment. We're still working on a cure, and I'll tell you a little bit about the future directions of the field towards the end of the talk. But we do know that exercise does work to slow disease progression. We're still unsure as to the specific kind or intensity of exercise, but exercise nonetheless has been shown to slow disease progression. Finally, I treat my Parkinson's disease patients as if they have a whole body disease. And I use the mantra, train, not cane. Remember going back along the Parkinson's disease train, all of those cars that have been added up along the way: constipation, depression, sleep disorder. I do not just treat their tremor. I treat all of those problems every visit. So a patient coming to me for a follow-up visit for their Parkinson's disease will not only get medications adjusted to control their tremor or their movement disorder, but they may have medication adjustments to help them with their sleep, their mood, or their constipation. Oftentimes, I treat patients as if they're my own primary care patients, as best I can. And that also includes a multidisciplinary approach with other professionals involved. And I'll go over who you want on your team next. Finally, I don't just send patients back to their primary care doctor after they're diagnosed with Parkinson's disease. Once I diagnose you with Parkinson's disease, you're my patient for the remainder of your disease. I may follow you every 3, 6 months, or yearly, depending on how stable you are. So who would you want on your team? It's really up to you. You're the captain, and you've already come to see me, which is great. Patients who have a movement disorder specialist have been shown to have better outcomes with their Parkinson's disease. They also show better outcomes when they receive regular physical, occupational, and sometimes speech therapy, which we provide right here at Baystate across the parking lot at our outpatient rehab center. Along the way, patients may be struggling with mood disorder or psychosis, where a behavioral health specialist is also required to be part of the team. You may want to work with a counselor or have a psychiatrist as part of your team. Finally, at the more complicated end stages of the disease where patients may need more support and are not thriving at home, a placement by a social worker in a nursing facility or assisted living can be helpful, and going over your end-of-life wishes. But don't leave out your family and friends and your community. There's a tremendous support in the community around the Springfield area for patients with Parkinson's disease. Just listing off the top of my head, there are specific exercise programs offered at YMCAs. There's Tai Chi courses offered at Springfield College. And there's private physical therapists in the area that are in tune with the latest Parkinson's disease rehab research. Now, I'm not going to spend a lot of time on medication today, but I just wanted to highlight how many medications we have to treat symptoms of Parkinson's disease, and that a movement disorder specialist will know all of these, including myself. However, you'll need different medications at various stages of your disease. And so this is just a teaser on what's to come for my next talk in the series, where I'll be talking more about the treatments and medications for Parkinson's disease through the various stages of disease. So stay tuned for next time, and I will be talking about medications. So I talked a lot about exercise as the one way to slow disease progression, but a lot of times patients follow that up with what do they need to do to slow disease progression with their exercise? Should they be hiking, biking, walking, weightlifting? Again, I'm going to address this in the third part of my series later this summer. So again, tune in or watch the recording when it's posted. Just as a teaser, the MIND diet is important for brain health, MIND, as well as balance exercises such as Tai Chi. I'll be talking about more diet and exercise later this summer. And lastly, what are the most advanced, latest treatments for Parkinson's disease? And what does Baystate have to offer? Well, if we go back to where the problem is in the brain, the deep part of the brain where the dopamine cells are degenerating, how else, other than replacing the dopamine, can we give patients relief of their symptoms? Well, one advanced therapy is called deep brain stimulation. And what deep brain stimulation is low current stimulation to the area of the brain where the dopamine cells originally make their connection. If you think about it, this is a pacemaker for the brain where the electrical signals that the dopamine cells used to give are now replaced by a stimulator. And we offer this advanced treatment here at Baystate, and certain patients that I identify that could benefit can get this procedure done here. Other more advanced treatments for Parkinson's disease include focused ultrasound therapy, which uses high frequency ultrasound waves to make a lesion or ablation in the part of the brain that's causing certain Parkinson's disease symptoms. Finally, I am working with our GI department on offering the Duopa system, which would be a percutaneous delivery system to the small intestine of a continuous infusion of the medication used in Parkinson's disease, such that patients do not have to take medication 3, 4, or even 5 times a day. They program their pump and forget it. We offer currently 2 deep brain stimulation systems here at Baystate in partnership with my colleague, Dr. Richard Ogbuji of neurosurgery, who does the actual implantation once a patient is identified. This is Dr. Ogbuji here on the left, and this is myself. This is an image of a successfully implanted patient in which the deep brain stimulator device has been targeted to one of the deep brain areas responsible for tremor in Parkinson's disease. I'd like to close by raising awareness for the Parkinson's disease support group that recently met for its first meeting on June 1st at the Jewish Community Center in Springfield. This is a huge step in the community, and I'm so proud to be able to offer it to patients here at Baystate. I work very closely with the regional leader of the American Parkinson's Disease Association in Boston, and together she has trained a wonderful facilitator. Her name is Corey Tratner, who is a retired occupational therapist whose husband was lost with Parkinson's disease, and she wants to continue giving back to the community and raising awareness for patients with Parkinson's disease in the area. So please take down her contact information from this flyer or email us after the talk today. We will post this as a link from the presentation. And with that, I'd just like to thank you for attending my talk today. Again, this is the first part of a 3-part series in which I'll try to address as many questions as possible. Please do not feel left out if I do not get to your question. Thank you.
Thank you, Dr. Martin. That was really great. Is that Ozzy?
Yeah, so this is Ozzy Osbourne, who publicly came out with his diagnosis of Parkinson's disease. And I just wanted to reinforce again the train concept rather than the cane concept. He does look like someone who has Parkinson's disease for sure, but in the background, he probably struggled with a lot of these other issues before his formal diagnosis. And that's what I want you to take away from the talk today.
Wonderful. I also appreciated your images of Ted Lasso too. Great, great metaphors there. That was great. We do have some questions. So, and I believe you answered the first one during your talk.
Yes.
So I guess we don't have to address that one. We'll skip down to the second one. What makes someone a candidate for deep brain versus focused ultrasound?
Yes. So both of these treatment options are considered advanced treatments for Parkinson's disease. So first of all, it's all about the goals of therapy when a patient is considering advanced therapies. Right now, deep brain stimulation is offered for patients who want better control of their movement symptoms. So specifically, deep brain stimulation, if your goals of therapy are reducing tremor, reducing dyskinesia, and dyskinesia is different from tremor. Dyskinesia is a larger amplitude. Remember how big the movement is, usually of an arm or a leg or a wiggling movement. The other things that deep brain stimulation can improve is the stiffness or rigidity and the slowness of movement. Now, deep brain stimulation can be implanted, a neurostimulator can be implanted on both sides of the brain and help both sides of the body. It can be turned on and off and adjusted up or down, depending on the severity of the symptoms and the side effects patients are having from stimulation. Now, in comparison, focused ultrasound therapy is an ablative therapy. There's no hardware that's implanted. And right now, It's only FDA approved for unilateral or one side of the brain, and it's primarily directed towards tremor control. It may help with some of the other symptoms of Parkinson's disease, but the greatest evidence has been shown in reducing tremor. And it's usually trying to reduce tremor on the patient's dominant side. That if you're right-handed, they'll target the left side of the brain. If you're left-handed, they'll target the right side of the brain. And the focused ultrasound therapy is offered. It's not as widely available right now. It is becoming increasingly popular. And it's also a decent consideration if a patient may be considering a non-incisional advanced therapy. It's still invasive because a lesion is being made in the brain. So I still consider it an invasive therapy. I use the term non-incisional. So if a patient is not able to undergo general anesthesia or has other medical comorbidities, and their goal of treatment is to reduce tremor on one side of the body, focused ultrasound therapy may be a better choice.
Excellent. Thank you. I just want to, before we go to the next question, remind the audience that they can type their questions in the Q&A box. And as long as we have time, Dr. Martin will be able to address them. Next one is Parkinson's disease hereditary? And are there any known risk factors?
Yes. So Parkinson's disease can be found in families. However, I'd call this the third myth of bust today. Most cases of Parkinson's disease are not hereditary or familial. I'd say 15% or less of cases are related to a gene, one specific gene that's passed down from family member to family member. That's called monogenetic inheritance pattern. Only 15% or less of cases are because of that. The remaining cases of Parkinson's disease are what we call idiopathic or unknown cause. Now, there are a few genetic locations that if you have a mutation, it raises your risk of developing Parkinson's disease, but they're not causative genes, meaning if you have the gene, it equals disease. It may raise the risk. And so that's actually an area of ongoing research, doing genetic panels to calculate someone's risk score. So if you think about it, there's a very small minority of patients who have hereditary Parkinson's disease, and that's typically diagnosed before age 50. So if you have a family member who's been diagnosed before age 50, a genetic cause of Parkinson's disease should be taken into account. Now, the genetic risk calculator, again, that's an area of active research looking at specific gene locations that may raise your risk of future development of the disease. That's a different thing that's being worked on currently as part of a risk calculator or risk stratification score. That's not widely available. So that's not part of my routine practice, is doing a genetic risk score for patients. That's primarily done for research purposes at this time. This follow-up part of that question was about risk factors. Are there risk factors for Parkinson's disease? Yes, there are risk factors for Parkinson's disease. The major ones that have been identified or linked to Parkinson's disease have been Agent Orange exposure during the Vietnam War. If people who served abroad in Vietnam who had exposure to Agent Orange. The other major risk factor would be chemicals or pesticides. There have been recent publicity about certain sorry, I'm losing my, I have to take a sip of water. Certain pesticides that have been linked to development of Parkinson's disease. The major one is called paraquat. And then finally, there are certain metals, metal exposure, specifically manganese. So any metalworking or metallurgy is a risk factor for future development of Parkinson's disease. What's interesting is that we've seen the incidence and prevalence of Parkinson's disease increase along with climate change. So as climate change gets worse, we're seeing a relationship between worsening things in our environment that is raising the risk of developing Parkinson's disease. That's another area of active research that's being fleshed out at the moment.
Oh, very interesting. Do you have water with you that you can take a drink?
Yeah.
Yeah, why don't you do that now while I'm looking for the next question? Let's see. Are there any online support groups or sites you recommend?
Yes. So one of my patients actually runs an online support group that he co-manages with a patient who lives in Australia. So it's almost like a world online Parkinson's support group that's searchable on Facebook. I don't know the exact name of it, but I think it's one of the larger Parkinson's support groups on Facebook. You do have to submit a request to join. Another resource would be the American Parkinson Disease Association and the Parkinson Foundation. The other resource would be the Michael J. Fox Foundation. Those are the three major national bodies that support patients and support ongoing research.
Excellent, thank you. The next question, when in the course of the disease is medication generally recommended?
Yes. So starting medication for Parkinson's disease is a personal decision, and different patients have different thresholds for starting treatment. So to just put it in clinical context, some patients may have social anxiety about going out to dinner with their tremor. And so they're restricting their things that they previously enjoyed because they have a symptom of Parkinson's disease, tremor. And when I go over this with patients, I kind of tell them that you're with yourself all day long. I only see you for 30 minutes or 60 minutes if it's my first time meeting you. So if you find yourself changing your behavior, I would start medication, or losing interest in life or activities that you previously enjoyed, I would start medication. The other way to ask yourself, or have someone weigh in on whether or not they should start a medicine would be, do they have any functional impairment? So are they able to go up and down the stairs and get into their apartment or home unassisted? Are they able to get up from a chair unassisted? So these functional immobility concerns may be a inflection point on when to start medication.
Very good, thank you. Next question. If you have a diagnosis of Parkinson's, obviously, for a couple of years, is it recommended to also have the skin biopsy?
So I always welcome patients to get second opinions if they've been recently diagnosed with Parkinson's disease and it's still a little unclear or they're unsure and they want some reassurance. So I would say if it's within the first year or two and you have very mild symptoms, it's not unreasonable to get a ancillary or helper test like the skin biopsy, or just see another movement disorder specialist for a second opinion. If you're diagnosed with Parkinson's disease and you're started on medication and it's helping you, meaning you have had a dramatic response to the medication and it's working for you, it's very likely that the diagnosis is correct at that point, and you should continue on medication. And I would not really question the diagnosis. If you were not responding to the medication you were started on, I would either be frank with your neurologist or ask for a second opinion.
Oh, good advice. Thank you. The next question, how do they differentiate the diagnosis of Parkinson's from normal pressure hydrocephalus?
Yes, so going back to our definition of Parkinsonism, meaning that slowness, tremor, or rigidity or stiffness in the muscles, again, one of the diagnoses, one of them being normal pressure hydrocephalus, a patient with normal pressure hydrocephalus may have some of those symptoms of Parkinsonism. So how do we distinguish if it's normal pressure hydrocephalus versus Parkinson's disease? So how we do that is by doing a lumbar puncture. We also take a look at their brain, either on a CT scan or CAT scan or MRI, and we look for the size of the spaces in the brain called the ventricles. In normal pressure hydrocephalus, the size of the ventricles is large. This would be atypical in Parkinson's disease. And to confirm whether or not a patient has normal pressure hydrocephalus, they need a lumbar puncture with a pre and post walk test. Typically, patients with normal pressure hydrocephalus after a lumbar puncture can walk better. Parkinson's disease patients usually need some medication or physical therapy to improve their walking.
Thank you. The second part of the question, or the two questions that they were asking, was what, if any, is there a correlation between bipolar disease and Parkinson's? And can the medications for bipolar disease cause Parkinson's?
Okay. Yes. So this question gets at something that I come across very commonly, almost on a day-to-day basis, which is the question of whether or not their Parkinsonism is caused by medication effect, or if it's caused by Parkinson's disease, or in some rare cases, both. So to sort through that, my typical pathway is to order a DAT scan. Sometimes it's also helpful if patients do not, for whatever reason, cannot get a DAT scan, I would revert to trying a skin biopsy or a withdrawal of the offending medication in coordination with their psychiatrist. So if a patient comes to me who's on a medicine that blocks dopamine, the most common medicines that block dopamine are the neuroleptic or antipsychotic medication class. These would be medicines like haloperidol or risperidone or aripiprazole or prochlorperazine. These medicines block dopamine in the brain. And when you block dopamine in the brain, you can get symptoms that look like Parkinson's disease. However, I can't just take patients off of their mood stabilizer medication because of the risk of psychosis or mania. So that has to be done under the supervision of a psychiatrist or behavioral health specialist. And I work closely with patients' psychiatrists if that needs to happen.
Excellent, thank you. We only have a few more minutes.
Okay.
The next couple of questions. How long does it take for Parkinson's disease medication to work? And can you take it as needed for events and cease, or do you need to continue to stay on Parkinson's medication?
Okay. So typically if someone has Parkinson's disease and they have clinical symptoms, either tremor, rigidity, or slowness, they should notice a benefit on a decent dose of medication. The major medicine used is carbidopa, levodopa. Typically that takes effect within 30, sometimes 45 minutes for patients. There should be a measurable effect, but that depends on how advanced the disease is. Some patients may not appreciate that much of a benefit with medication if they're in the early stage of the disease, because their brains are still able to compensate for the lack of the dopamine being produced. They don't need the extra levodopa to make more dopamine. They're already trying to ramp up their natural ability to make up for the lost dopamine as it is. So adding more medication in the early stages of the disease sometimes is not helpful. Now, can you take it as needed? I'd say if you're on the medicine and it's helpful, I would take it on a regular basis. And the reason why I say that is because the medicine does not stick around in the brain very long. Once dopamine is sent out of the brain cell, it gets broken down very quickly by enzymes in the brain. And so taking the medication on an as-needed basis is not really going to give you a sustained benefit that you're looking for. You'll need to take it at least 3 times a day to get benefit.
Very good. It looks like we've run out of time, Doctor. It was a great presentation, great questions, and I'm excited for all the great new things coming for Parkinson's disease. I applaud your work. Someone did mention about the video, and they'll be able to see it by the end of the month at baystatehealth.org, or they can go to youtube.com/baystatehealth to see the video, this recording. And as Dr. mentioned, we will have more events coming up. So I thank you, Dr. Martin, for your time, and for our audience, thank you for joining us.
You're welcome. Thank you, everyone.